A very good morning to one and all. At the outset, I would like to thank Dr. Jethani for including me in this IC. I'm really regretting missing the physical meeting, but I hope to do my share by contributing my talk. So I'm going to talk about community outreach in myopia. So my talk is going to be based on a few W questions related to the community outreach. So that's going to be the mechanics of my talk. So let us begin with why. So, why is myopia a problem at all? So, we need to understand that it's an important public health problem. The rate of myopia among high school students is reaching as high as 80 to 90% in some Asian countries. It inversely affects the quality of life and can cause a huge economic burden on the society. The WHO has estimated 19 million children to be visually impaired, of which 4 million are blind. In India, zero point 0.8 per thousand children are blind. Half of the causes of blindness are preventable or treatable. In India, 270,000 children are estimated to be blind, and refractive errors forms the commonest cause of visual impairment outside the blind school. So, in the blind schools, it's the corneal and the lenticular opacities which are the common causes for the blindness. So, as we know, myopia is increasing at a hugely rapid rate. Half of the population is estimated to be myopic by 2050, with around 10% of the kids having high myopia. So, why do we need to control myopia? We now know that there is a high incidence of ocular morbidity and visual disability with higher the myopia, higher the chance of retinal issues, risk of glaucoma and cataracts, and also it involves a high cost of optical correction. Hence, screening for myopia can facilitate early detection and help us implement a good management to try and prevent the progression of myopia. So, how do we go about addressing this problem? The how is going to come again. This question I have divided in two parts. So, how do we deal with this problem? So, screening is something which is a very effective means of tackling it. The definition that I have put on the top is a WHO definition and a bit complicated. A simple way of defining screening is a relatively short examination that can indicate a vision problem or a potential vision problem. So when do we conduct these screening camps? Well, you're okay to do it throughout the year, but as per literature, it is stated to be from April to September because mainly the load of cataract surgeries increases from October onwards. However, if you have dedicated people to do the school screening or team to do it, you can do it throughout the year. The only thing that you need to take into consideration are the children's vacations and their exam schedules. So where do we really go and conduct these camps? So the centers that are to be tapped are the schools, the community centers, at community events, and sometimes in in-house clinics. Now this has a dual advantage. First, we can identify the kids who have a problem and help in their referral and treatment. Second, this can also act as a small marketing tool for the center and the services that are provided by the doctor and create a better name in the community and in the neighborhood. So whom? Now whom is the screening done by? So it is generally the teachers, the optometrists and the ophthalmic assistants. So in India, the commonest approach has been through training of school teachers who do the initial vision screening and refer patient with suspected abnormal vision. In some areas, all the school teachers in a particular school undergo training, while in some other schools, there may be a few select teachers. The advantage of training all teachers is that the class teacher can themselves administer the screening and the students tend to be more comfortable with their regular teacher. The community screening camps can also be conducted at primary health centers during some community gatherings, as in during Ganpati or some Navratra, or as a part of a health camp in a particular area. The ophthalmic assistants and the optometrists are the backbone of this screening. The tests that are done during screening include an uncorrected visual acuity estimation, which can be accompanied with an autoref reading or a photo screener. In some settings where there are stay cams, a cycloplegic retinoscopy or autoref is also done, and the glasses are dispensed at the same time. In some other areas, or probably in house clinics, we can further our camp services by including a biometry as well. Now, in all of these models, the essential parameter for success is provision of spectacles. All our efforts are futile if this is not looked into. Most commonly, the children are prescribed the correction and the glasses are made available for designated optician. In some camps, the organizations may dispense the spectacles on the spot. Now, whom is the screening done for? So, the pediatric population is subdivided into three age groups: 3 to 5 years, 6 to 9 years, and 10 to 15 years. For myopia specifically, the screening is recommended from 5 years onwards. However, certain screenings are also done in Anganwadi camps where probably a photo screener tends to be the most useful. While the screening tends to be the most successful in the 10 to 15-year age group because the kids are more aware, they can vocalize that they are not seeing well and can ask for a proper referral. So again, we come to the second part of the how question as to one, how is the screening program initiated and how is the actual screening done at the campsite? So the National Program for Control of Blindness had initiated the school eye screening program in the year 1976. This is primarily administered by the respective state governments in collaboration with the district health authorities as well as through public and NGO institutions. The school eye screening program has become an integral part of NPCB since 1994. It was initiated after successful implementation of a pilot program in 5 districts, which was again a school teacher training program. The actual planning of the school eye screening is done by the respective district health societies. They look at various parameters like holidays, examination, involvement of teachers, availability of human resource when they do the planning on a large scale. So what is a school eye health program supposed to consist of? To identify children with refractive errors and dispense glasses, educate them about the eye condition and eye health, provide primary eye care for children, and have a school environment that promotes good health. The school eye screening program in India, as we talked earlier, the teachers and or the ophthalmic assistant visit the school. They have been given with a toolkit which includes a measuring tape, a visual acuity chart, referral card, and educational material. One thing that I would like to state is basically the advocated vision card is the e-optotype card because that can be randomized. The other Snell and Acuity cards can sometimes be by-hearted by the kids and may not provide us with the accurate referral. The teacher indicates a subnormal result when the vision is 612 or lesser, or also in case of a doubtful response. In the era of smart age, we have apps which can be used for school eye screening. So this is a Peak Vision Acuity app, which is a simulation tool which can actually compare the child's vision to clear vision, which can be printed and be handed over to the parent or the caregiver. So in this app, you can just download it from the Play Store. It gives you a tab for calibrating it. You need to measure the height and width of the arms of the E. Once the calibration is done, you need to measure the vision at a distance of 2 meters, 1 meter and 30 centimeters. So a string of those lengths need to be carried at the campsite. The app gives you the vision, which has to then be compared, which then gives a simulated result against a normal vision, which can be, the report is then shared with the stakeholders of the camp and the report is passed across to the parents for appropriate. Now, what really goes into planning this screening? So there's this module called as a Sahara survey module, which is School Eye Health Rapid Assessment Tool. So this is one way of actually planning the screening. So it gives us a scale or a survey to how the camp should be planned. So the step one is estimating prevalence of visual impairment in school children in each global burden of diseases region. The proportion of children requiring eyes, this is estimated. Then a cluster survey design is used with schools being the sampling units. The sampling stream of the schools is attained from the relevant authorities. Then the further cluster nature of the data is collected. So this is some correction factor for allowing the loss of variation in the sample. The sample size calculations for different global burden of diseases region is done. The prevalence range is considered to be in the range of 4 to 19% for school children across the globe. This then goes through stages of, once this is conceptualized, the stakeholders are interviewed, then there are advisory group consensus meeting, then an output is formalized. So this is how is the actual planning that goes into designing these school eye screening programs. So the main people who are actually very active in this is the site savers who have a program called the Vidya Jyoti School Eye Health Program, and the RBSK, which is Rashtriya Bal Swasthya Karyakram, which provides free treatment from birth to 18 years for 4Ds, that is defects at birth, deficiencies, diseases, and developmental delays. The final recommendations include that the children should have annual school-based vision screening throughout the childhood and adolescence. Screening up to 5 years of age can be integrated with the universal immunization program of the government, and beyond the age of 5 years, it should be a part of the annual school health checkup. Thank you very much for a patient hearing.
Yes, I think we had a great talk by Dr. Prachi, and the importance of screening in our communities when we are doing cataract screenings, and extending the services to the kids or grandkids of these patients would be